Good evening, ladies and gentlemen, and welcome to Menzies. My name's Tom Marwick. I'm the director here, and it's a pleasure to see all of you to come to the third annual Menzies Debate. And on the University of Tasmania wishes to acknowledge the Muhina people, the traditional owners and custodians of the land on which the campus was built. Well, we've all come to hear the debate about this particular statement about prostate cancer screening. And in a few minutes, we will introduce the teams to you. But I want to put this in the context of the previous debates that we've had. We've had debates about testing for vitamin D in the community. We had some very interesting props for that one, if you remember. We had obesity surgery last year. We gave some things to the debaters that would help them do their own obesity surgery if that became necessary. And who knows what props we will end up with today. So these debates are really, really play to the strengths of Menzies as a population health-based institute. As I'm sure all of you know, we have 5 major themes here, and this third debate is about the cancer and genetics theme. So we spent some time thinking about this topic, and surprisingly, we had a few misgivings at the beginning. The men in the audience are looking as though they understand, the women perhaps less so. But the response to this has been interesting. Just a week ago, Miranda asked me to take a call from a newspaper, and the caller was asking what was controversial, I should say what the heck was controversial about prostate cancer screening. Well, by the end of tonight, if you don't think it's controversial now, I hope that you will believe that it's controversial then. So here I am, a cardiologist, asked 2 days ago by Miranda to give the introduction to this meeting for about 9 minutes. And I thought, well, I can't really do that, but I did think back to the beginning of my career. Those of you who are familiar with Brisbane would recognize this hospital, the Princess Alexandra Hospital, and I was a urology resident there in 1982, and that's quite sufficient expertise, I would think, to give the introduction. Now, this was a very enjoyable time for me. I had a deal going on with the urology registrar. He went to theatre and dealt with all the prostates, and I stayed down in the ward and dealt with the post-operative complications, which was, really played to my interests and to his as well, so that was all good. So for those of you that are not so familiar with the prostate, it is a small gland about the size of a walnut, normally, that sits underneath the bladder. Now, I spent a lot of time on the internet looking for this particular image. All the rest of them were full frontal, and I thought it would be much too controversial. So I've put this one in there just so that everybody knows where the prostate lives. Now, just before we start the debate, there's a few things about prostate cancer that you should know. It is the most common cancer among men after skin cancer, and it can be treated successfully. 1 in 6 men will be diagnosed with prostate cancer during their lifetime. It's very rare in younger men, and most of the diagnoses are made in the 65 plus age group. So this is a common problem. It accounts for 28% of cancer cases in the US. I think it's analogous here. And 10% of cancer deaths. So this isn't a benign disease. It's a very common disease. It's not a benign disease. The lifetime risk of developing cancer, if you look through all sites there in men and women, about 40% risk. Prostate cancer, about 16% in men. The lifetime risk of dying from cancer, the numbers are smaller, but in prostate cancer, about 3%. So a common problem and potentially a very malignant one. But the thing is that prostate cancer is a disease of old age, and more men die with prostate cancer than of prostate cancer, and I'm sure that is going to be something that comes up in the discussion this afternoon. So the cornerstone of screening for prostate cancer is a blood test. that is based on a chemical that is found within the prostate that leaks out of the prostate when it's unhealthy. And of course, it's not just cancer that causes the prostate to become unhealthy. And conversely, you could have a small cancer that's very malignant that's not leaking very much. So what is the evidence about screening? Now, the debaters are going to go into this in some more detail, but when this kind of data is gathered from multiple studies, as you see here, this is called a meta-analysis. And the more the procedure favors screening, the more you'd expect to see the dots down here, and the more that it doesn't favor screening, you'd expect to see them down here. These dots are standing pretty well over the line of identity there. So not really much evidence that screening is beneficial across populations. And as you'll hear this evening, interventions have risks. So 2 years afterwards, there's a significant number of people that undergo surgery or a consequence of prostate screening who develop urinary incontinence or sexual dysfunction or bowel dysfunction. So this is a common problem. It's a potentially very dangerous one. At the moment, we don't have a strategy that we think is effective across the population. That's the reason why Menzies is particularly interested in this. So that is the limit of my expertise about prostates. That's not bad, really, for a cardiologist. I'm going to hand over now to Bernie Hobbs. Bernie, I'm sure, will be known to many, if not all of you, as an award-winning science writer and broadcaster with the ABC. Bernie has helped us previously with one of these debates, and I think you will find her a very engaging moderator for the proceedings. So Bernie, it's a pleasure to hand over to you. Thanks for coming back.
Thanks, Tom, and thanks everyone for coming along tonight. And it is great to be back for another debate. I enjoyed the last one so much, had a lot of fun here. And I think it's hard to imagine a topic that could be of less relevance to me, really. So not only do I not have a prostate, I don't like walnuts. So, but you know, I think in the political scene we're living in at the moment, the being seen to be impartial when you're the chair of something like this is pretty critical. So well selected, Tom and team, in getting me down here, very neutral on the whole issue. You know, like all Australians, though, I'm very aware of screening, especially Australians who recently turned 50. So now I have the pleasure of adding regular mammograms and colonoscopies to the biannual delight that is the pap smear. So gentlemen, if you're looking for any sympathy from women tonight for having to have the odd blood jab at the GPs, I don't think you'll be getting it. Can we just get a little bit, you know, it's obviously an interested crowd here this evening. Can I just see a show of hands if you have a prostate gland? Okay, that's fairly heavily weighted in the you know, personal interest. Hands up if you are walnutless in the gland department. Okay, good. So just we've got some sprinklings of almonds, which would be what they like to describe ovaries as throughout the crowd. If you love someone who has a walnut, self-love counts. Yeah. Okay. I'm not even sure what I'm going to learn from that, but I feel like we're getting to know each other a little bit this evening. Now, tonight is a debate, and you know with debate there's always an element of performance involved. So we've got 6 experts who either have a prostate, work with prostates or in the prostate cancer field, or have a very strong interest in cancer and cancer screening in Australia, but they're not actually necessarily going to be giving their own opinions. They're going to be doing whatever it takes, and I think we've already heard an allusion to props, and no doubt there'll be some bad jokes as well. They'll be doing whatever it takes to swing you over to voting for their side in the debate. But have no fear, at the end of the debate, we'll go to a legitimate question and answer when you can get your real questions answered by them in their real perspectives. And of course, it's a debate, so we're going to have winners and losers. It's not this new age, oh, everybody's a winner. There will be losers. 3 of you, to be specific, will be actual losers tonight, okay? So, and the decision is down to you. I'm queen impartiality, no walnuts here. So the decision is all about you voting for yes and no. So you would have seen on your seat this evening this little raffle ticket looking piece of work, and what it is 2 sheets of paper saying yes, all men aged 50 to 69 years should have annual prostate cancer screening with a PSA test. So 2 of them, and 2 red ones saying no, all men aged 50 to 69 years should not have annual prostate cancer screening with a PSA test. So the way we're going to work it, because we're quite rigorous here, it is a medical research facility, there'll be no counting of hands and fudging results. We're going to do an actual written survey, probably for publication, because in the current academic environment, if you can't publish, what's the point, really? Even in a Science Week debate like this. So what we're going to do, before you hear the arguments, before you see the props, the interpretive dances, God knows what's going to come from the stage this evening. Before you have any of that sway your mind at all, I want you to give a baseline vote of what your position is now. And that means for every one of you to take either the yes or the no, just one of them at this stage, and pass it towards that lady in the red coat seems to be collecting them. Now, if you can pass them down your rows, and we're going to be collecting those on either side, just the one that you think now, before your mind has been influenced by our courageous, dare I say, foolhardy debaters this evening. Very committed. So, yes, you think it should be compulsory for all men 50 to 69 to have PSA screening, or no, you don't think it. And your mind may well be changed by our debaters this evening. No, the debaters themselves are not, oh, okay, yes, yes, put in your 3 for your team each, whatever. Why start with formalities now and rigorous rule making and obeying? Okay, how are we going with that? So we'll do that again at the end. But, I mean, we don't have to be that rigorous, like it's not secret ballot. Now can I get you to show your hands if you just voted yes, it should be compulsory? 7, 8, 9, 10, 11, 36, 84, 200, yeah, not sure. And show your hands if you voted no just now. Okay, you're only allowed to vote one way or the other. I know you've got 2 pieces of paper. That was pretty close. That was a lot more close than someone like Mark was expecting. So I hope you have actually written a talk tonight, Mark, because there's going to be a little bit of sway to do here this evening. Pretty close, I think, there. We'll get the actual numbers a little bit later on. But before we go any further, I would now like to introduce to you our speakers. On this table, we'll have the affirmative team. On that table, the negative team. So join me in welcoming our first affirmative speaker, Professor Mark Nelson, Chair of General Practice Yes. Mark doesn't stand on ceremony at all. No, don't be fooled by that. First negative speaker, Dr. Liesl Fitzgerald, also based here in Tassie. I'll give them more of an introduction when they're actually speaking. Our second affirmative speaker is Penny Egan, the CEO of the Cancer Council. Our second negative speaker is Professor Frank Bowden from the ANU and Canberra Hospital. Second negative, yes. Our third affirmative speaker is Michael Vaughan, neurologist here at Hobart Private. And our final speaker, our third negative speaker, is Paul Glazou. He told me to say it like I was sneezing it. Glazou. Paul Glazou. PA is a professor of evidence-based medicine who's come down from Bond University on the Gold Coast. Now, being a debate, we have some actual rules, and prime among them is the 5-minute limit, okay? No matter how good you are, we're going to be pretty bored if you go beyond 5 minutes. And I'm going to give you a 1-minute warning at 4 minutes. You've each been held back, even though a lot of you are academics, you've been restrained to a maximum of 3 slides, okay? So I don't want to see any trickery, trying to allude to something really being part of a great subset and you having 27 slides up there, okay? We have no tolerance for slides. 3 slides, 5 minutes with a warning at 1 minute, and at the 5-minute mark, in keeping with the theme this evening, not only will I be ringing a bell, but I'm going to make the sound of water running, okay? And I'll be talking a lot about showers and taps and hoses and things. So if that doesn't stop you in your tracks, I can't think what will. But you're being cut off at the pass at 5. We'll go first affirmative, first negative, all the usual stuff. It says there'll be no rebuttals, but I'll leave that to you to interpret as you like. There'll be no extra time for them, that's for sure. And at the end of all 6, we're going to re-vote with your torn off ones again to get the official publishable data, the evidence base for the debate, and then we'll do a show of hands as well. So are we all good with the rules? Yes. More importantly, are we all good with the rules? I know I glossed over some of the more critical ones. Okay, so I'm now going to officially kick us off. I've got my 5-minute timer ready to go. And please join me in welcoming to the stage officially Professor Mark Nelson. And just a bit more background. So Mark's the Chair of General Practice at the University of Tasmania and a senior member of the Menzies Research Institute. He's also a GP in Hobart, and his research interests are large-scale clinical trials in cardiovascular disease prevention in primary care. So, Mark, your time begins now.
Thank you, Bernie. You can obviously hear me? Good. Okay, so thanking you for allowing me to speak on this very important topic for men's health. We will argue, I hope very convincingly, that all men aged 50 to 69 years should have an annual prostate-specific antigen, and that is what PSA stands for, test. This recommendation is under the principle that prevention is better than cure, although technically PSA screening is the early detection and treatment rather than prevention per se. You may be unaware that the learned team opposite, only one active clinician is on that group, and that clinician is an infectious diseases specialist. And I can tell you, prostate cancer is not an infectious disease. Whereas on our team, I am a GP who deals with this problem with my male patients on a daily basis, and Dr. Vaughan is a specialist urologist who deals with prostate cancer in that capacity. And not our token female member who doesn't have the appropriate gland, but Miss Penny Egan is CEO of the Cancer Council Tasmania, an organisation with a literal vital interest in the topic. So let's get one thing clear right from the start. It is prostate cancer, not prostrate cancer. The former is a reproductive gland that sits at the base of the bladder, and the latter is what you may have to do as an alternative to a PSA test, which is what the negative team will have the gentleman in the audience doing by opposing this proposition. As a poor speller, I thought I needed to get that errant R out of the way early. My first slide is well chosen. I'm sure that the other side will try to bamboozle you with figures, while we will keep all our attention on what is really important, the men at risk of prostate cancer. Rest assured that all men are at risk of prostate cancer. If you are a male and live long enough, you will develop prostate cancer whether you're aware of it or not. So you must be sure that you get it early by attending your GP and getting the test. Earlier disease tends to be more aggressive and is the one that needs to be captured. Being a man is standing up for your responsibilities, and one of your responsibilities is for your own health. Man up and get the blood test. Your doctor will want to know your cholesterol and diabetes status and check your blood pressure, so it is no biggie, as the PSA can be done on the same sample. One of the unforeseen benefits of Viagra, and I'm sure you know the obvious benefit of Viagra, but when it came onto the market, is that other male reproductive organ is a vascular organ. and its dysfunction is associated with other forms of cardiovascular disease, that is, heart attack and stroke. And they are actually the biggest killers of men. Now, when Viagra came onto the market, it meant there was a reason for those men to visit their doctors. And we could then assess them for stroke and heart attack risk, and we could appropriately treat the risk factors for SAID. So what I'm saying is that PSA screening has the potential to do the same thing. If there's a reason for them to attend, then not only will they have their prostate attended to, but we'll also look at their other diseases at which they're at risk of. I said that I would not bamboozle you with figures. However, there is one figure that you ought to know. According to an Australian, I'm giving you Australian, Tom gave you US figures, an Australian Institute of Health and Welfare report, prostate cancer is the leading cancer among males, and the only figure I will give comes from that report. That is that 3,294 men died of prostate cancer in 2011. That is 3,294 fathers, brothers, uncles, sons and grandfathers. This is not only a tragedy for these men, but the families that they've left behind. As a clinician, I have to deal with a grieving family who can well ask, could I have done something to stop this happening? How many consultations do I have before I'm convinced of the need to act? I don't want to be also put too selfish a slant on this, but I don't like dealing with the coroner and the Health Practitioners Board for what was a potentially avoidable death. So you fellas out there, see your GP and ask the women in the audience to encourage the men folk to do so. It has been shown that men who are partnered live longer and healthier lives, and a PSA suggested by their partner may be one of the reasons that they do. Thank you.
I don't know how many rehearsals you had to do, but you came in exactly on the 0-0. You did train for it. Well, let's hope your expertise doesn't end there with the good timing. And what is funny is that you slagged off Tom, who's not actually on the opposition, but he's like the chair of this grand establishment that I believe you're only a senior member of. So smarts may not be your strong suit there tonight. But I did like that you were appealing to the young'uns here tonight with your talk of manning up, and it's no biggie. You are totes on track to be down with the kids. Yeah, you're all over it. You're all over it, Mark. So well done, and don't worry, everyone will get that degree of love from me this evening. It's not a partisan approach at all. Now, our second speaker, join me in welcoming to her official talking place, is Dr. Liesl Fitzgerald. Now, as Mark pointed out, Liesl is not a clinician, but she has been investigating the genetics of prostate cancer for over a decade, here and overseas, and she's a member of a couple of international consortiums looking into prostate cancer, and she's just returned to the Menzies this year, a couple of months ago, to continue her research into identifying screening and prognostic. Sorry. That's my ticker. It's not so good, so don't shock me. No, I'm kidding. It's the mic in front of the speaker. All right, join me in welcoming for her 5 minutes, which will begin right now. Liesl. Oh, are you ready?
No. Is it working? Can everyone hear me? No. Hello, 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 hello.
You speak up a little bit.
Hello?
You know. No, it hasn't yet. You know what? Do you know that? That's bad.
Hello,
Don't
hello,
do that. Yeah.
Wait a minute, can you hear me now?
Can you hear her now?
Hello?
Otherwise, I can just repeat everything you say. Okay. All right, Liesl Fitzgerald, the first negative speaker. Men 50 to 69 should not have annual PSA screening. Over to you, Liesl. Pressing start now.
Good evening, everyone. Okay, so I get why men and their physicians have so readily taken up the PSA test. But historically, the PSA test was designed to detect recurrence of prostate cancer after treatment. This test first got approval in the States in 1986, but seeing a far more lucrative market in detection, in 1994, despite strong evidence to the contrary, the FDA approved the PSA test for prostate cancer diagnosis. What was this evidence, I hear you ask? Here are the results of the study that directly led to FDA approval. For every 100 men who aged between 50 and 75 who underwent PSA testing, approximately 15 had PSA values greater than 4. These men underwent biopsy, and of these 15 men, only 4 to 5 had prostate cancer. So 2/3 of men underwent biopsy needlessly. Since that fateful first study, countless more have demonstrated what a bad decision the FDA made. Studies repeatedly show that men who undergo a biopsy after a PSA greater than 4, only 25 to 30% have cancer. Where else would you accept that an outcome was wrong 75% of the time? Excuse me, I asked for a double espresso. Oh, oops, sorry mate. I tend to get the orders wrong 75% of the time. Or how about something a little more serious? Picture 2 mechanical engineers surveying a newly completed plane. Bob, you realise that wing is on upside down. Sally, don't worry. Guidelines state we get things wrong 75% of the time. Well, how about this? Doctor, so my PSA test, does it look like I have cancer? Well, sorry Dave, we've got to send you for a biopsy. You've got an elevated PSA. Several days later, after a lot of mental anguish, painful biopsy, which left him with an infection, I may add, Dave finds out he doesn't have prostate cancer. His PSA is elevated for a number of many other factors. Bah, humbug, I hear you mention. How often would that happen? Well, I can tell you exactly how often that would happen. Positive predictive value, sensitivity and specificity are well-known measures of a test screening ability. If we have 100 men who have undergone a PSA test and have a level over 4, send them off for biopsy, 2 of the largest international prostate cancer screening studies have shown that only 25 men will have cancer. So these tests have a 25% positive predictive value. In other words, as I mentioned earlier, 75% of men are biopsied needlessly. Furthermore, if we test 100 men with prostate cancer, studies consistently show only 21 to 47 test positive. In other words, over 50% of men with cancer are missed. Finally, if we have 100 men that we know don't have prostate cancer, studies show 92 to 94 test negative, showing that the tests give false positive results for 6 to 8% of men. In general, a test is said acceptable if it has a sensitivity greater than 50%, a specificity greater than 95%, and while there's no such cutoff for PPV values, if we compare it to the PAP test for cervical cancer and the IFOB test for bowel cancer, these both have PPVs greater than 80%. With all this evidence demonstrating what a poor screening tool PSA is, you may ask why it's in effect today. But it doesn't stop there. PSA screening doesn't take into account several important factors, including between test variation, age, ethnicity, and common genetic variation, all of which have been shown to affect serum PSA levels. So there are countless reasons why PSA is such a poor screening tool. Finally, I would like to leave you with this key thought. It's not just about whether PSA screening is effective, and I hope I've convinced you that it isn't. It's also about whether it does more good than harm. And my esteemed team members will demonstrate shortly that the PSA test definitely does more harm. Thank you.
Absolutely beautiful in the timing. You came in with 3 seconds to spare. I hope your research is a little bit better than your counting, because I saw about 11 slides up there during your presentation. In what way was that only 3? In what way was that only 3 slides? And of course, the great thing is, the only 2 anyone paid attention to were the cartoons at the beginning and end. I don't know why academics insist on putting tables and graphs up. Everyone just goes, whatever, if it's important, she'll explain it. So just note for next time, just use your cartoon slides. I'm not even going to punish you because I think you did that with those boring, tedious explanations in the middle, okay, that no one even followed. All right, I hope no one else is going over the 3-slide limit. Thank you very much. Yeah, we can count, yeah, all right. Good, because she did have some fairly good arguments there. All right, now, Penny Egan is our second affirmative speaker. I already mentioned that Penny's the CEO of Cancer Council Tasmania. Has anyone, yeah, thank God there's a GP here before I choke on. I'll probably just use my glass if that's all right, you know. Infectious diseases, hello. Yeah, good. So Penny's got a great interest in cancer and screening, but equally interesting, she was the CFO for Forestry Tasmania. Not sure what the link is, but it's in her bio, so I'm reading it out. She's lots of men, okay. And now Penny was the one who wanted me to be very specific in saying that the opinions expressed this evening by each of our debaters are not those of Cancer Council Tasmania in particular. So join me in welcoming Penny Egan, the second affirmative speaker. And your time starts now.
Well, good evening, and unlike the other debaters here tonight, I don't have a health background. I'm not a doctor or professor, I'm a Mrs. So I'm going to add some other perspectives to tonight's debate. We are just talking about a blood test. Is it really such a hard decision to make? The test is just a test. We're not debating about the next decisions that should, could or must be based on the outcomes of the test. We are just talking about a simple, relatively painless blood test. PSA, it's an acronym. Is it because men don't know what it means that they are concerned about the implications? So with the help of my friend Google, I found out that there are 236 meanings of PSA. One is pot smokers of America. So I'm not sure you remember having the test. The other one is personal shopping advice and might test the credit card. But eventually the list does come to prostate-specific antigen test. So out of the 236 definitions, we definitely know it's there and it definitely says test in brackets. So getting stuck on the detail and not seeing the big picture is but one of the arguments tonight to support the proposition that all men aged 50 to 69 years should indeed have annual prostate cancer screening with a PSA test. From a career perspective, I've worked over 18 years in the forest industry, and although not a forestry phrase, the expression of not being able to see the forest for the trees has some relevance, I believe, for this debate. It is the trees that are taking over the public debate, versus looking at the bigger picture of being 50, potentially another 30, 40 or 50 years to live, and that's the forest. That's what supports this proposition. The trees, individually, they don't provide any shelter, they grow weak and they wither. But if you look at the forest, it's healthy, it's vibrant, it's living, and that's what we want our men to be doing. After many years of forestry and forestry debates, let me tell you, old growth now has a whole new meaning. So I'm an accountant. Numbers. Let me put forward some numbers. In 2012, there were 778,500 PSA tests done in Australia. In 2011, 3,294 men lost their lives to prostate cancer. And from 2007 to 2011, the 5-year survival rates for people diagnosed with prostate cancer was one of the highest at 93%. So to the men in the room, which statistic would you rather be? Someone who has chosen not to have the test, someone who has, or someone who wished they had? Let me give you another number, 30-ish perhaps. That's the number of pap smear tests that I've had in my life to date that I could remember. And that's not counting the breast checks, the skin checks and other areas where cameras dare to go. And I have to say I'm very thankful that I had that pap smear test because at 30 I did find myself with a test that wasn't too great. And realistically probably wouldn't be here if I'd not had that test. So what harm is there, men, in going to your GP and having a test? You can lie, you don't have to lie on a couch, you don't even have to take your clothes off. So some quotes. If it's important to you, you'll find a way. If not, you will find an excuse. It is important, not just to you, but to your partner, to your family. This is a test. How it determines or changes your future is a further decision that you talk about with your GP. But this is the first step, and it may well be a big step, and it may well be a nervous one. Christopher Columbus said, "You can never cross the ocean until you have the courage to lose sight of the shore." So be courageous. Every day at Cancer Council, we meet the most inspiring, courageous people. Some of those people took the first step. Some didn't want to lose sight of the shore. It's easy to put your head in the sand because you have no symptoms. It won't happen to me. I'm not old enough. There's no family history. Another quote, Stephen Covey, author of a very well-known book, The 7 Habits of Highly Effective People. He says, "I am not a product of my circumstances, I'm a product of my decisions." So without going through all his 7 habits, there are some that resonate more than others. He talks about being proactive and taking responsibility for your life and working on the things that you can do something about. He talks about begin with the end in mind and secure the future that you want to envision. And he also talks about sharpening the saw, preserving and enhancing the greatest asset that you have, which is you. So agree with me in supporting the affirmative to the... Oh my gosh, that's not mine. I think I'm... Sorry. Just let the cat out of the bag, so to speak. So if I could just finish with my slide, which is very boring compared to that one. It's about don't be a tree, be the forest. Think of the statistic that you want to be. It is important to you, so please don't find an excuse. Have the courage to lose sight of the shore and sail over that horizon. Be a product of your decisions and not your circumstances, and start that habit to be a highly effective person. Thank you.
And what really is great about that argument is it doesn't really matter what the topic was, because you can wheel that out again tomorrow night at the motivational speakers event that you're going to. It's really good to see. Now, that's what I'm saying about people not paying any attention to all your facts and figures, Liesl. They're just, association causal, for sure. Don't worry about that. We've heard from our first 2 affirmatives, quite rigorous in their arguments. We've heard from our first negative, also rigorous, if a little, over-visual in the slide department. And apparently we can't blame you for that one that's never going to leave my mind. And probably I'm not Robinson Crusoe in the room here on that front. But now let's get to our second negative speaker. But before we do, I have the results of our initial vote, just to put a bit of quantitative data on the table, of our crowd of, 206 here tonight in a room with seating capacity for 200. That's what you get when you let the debaters vote for themselves. We got, for the yes team, 121. And for the no's, 85. So negatives, you've got a little bit of work ahead of you. So you've got 2 more speakers. You've got to sway at least several of these people to win. All right? There's maths to be done. Okay, our second negative speaker is Professor Frank Bowden from ANU in Canberra. He's an academic at the medical school there and also a senior staff specialist in infectious diseases at the Canberra Hospital. Very interested in population health and controlling infectious diseases, evidence-based approaches, and his book Gone Viral, The Germs That Share Our Lives, is published by New South and possibly has some motivational top 7 things that highly non-contagious people do in it, which may be your quote for us tonight. Join me in welcoming Frank, whose time starts round about now.
Thank you very much, Bernie. I want to make it very clear to this audience that the negative team believes that prostate cancer is a very serious problem. And as the population ages, this problem is only going to get worse. The problem, however, is that prostate cancer treatment is not very good, and prostate cancer screening is also not very good. The evidence that Tom referred to earlier, the 2 large randomised control studies in Europe and in the United States, are the best evidence that we are ever going to get. It's never going to get any better. And if we take the most optimistic view of the results of those studies, we show that there might be a very small reduction in the number of people who are treated for prostate cancer who avert a prostate cancer-related death. And there may be a small survival benefit, although the American study does not show that. It's quite possible, therefore, that prostate cancer screening kills. Now, we don't know exactly why that is the case, but it is a fact. I believe, and I am an infectious disease doctor, I believe, and I in fact have evidence to show, which I will present to you tonight, that infection is a very important part of that. Now, I want to remind you before we go any further by turning some international data into Australian numbers. In 2009, about 6,000 Australian men had a prostatectomy. Now, of those 6,000 men, only 165 had a benefit. If we apply the most optimistic results from the European study, if we apply the American data, there'd be no benefit. But if we apply the optimistic European data, that's what we get. So 5,970 men suffered all of the consequences of the prostatectomy for no prostate cancer benefit. Now, as an infectious disease doctor, I want to say to you, if you're not frightened of germs, you should be. Janet Lee is not frightened of Norman Bates here in the psycho scene from the psycho shower scene. She's actually frightened of E. coli. E. coli is a very, very small bug which lives in your bowel along with a whole other family of gram-negative organisms. But if you have E. coli in your blood, the death rate from that is 5 to 10%. If you had a heart attack, your death rate at 12 months is 3%. So E. coli in your blood is up to 5 times worse than having a heart attack. And I want you to keep that thought in your mind. This, ladies and gentlemen, and I should say ladies, is your revenge on men for 30 years of pap smears. This is the TRUS biopsy, the transrectal ultrasound-guided biopsy, which is performed after you have a positive PSA test. You can see that the rectal probe is passed into the rectum, and then a needle goes through the transducer into the prostate. Can you think of the needle? Can you think of... Yeah. Can you think of a better way? Can you think of a better way of introducing gram-negative organisms like E. coli into your prostate gland, causing an infection in your urinary system, and then spreading into your blood? And in fact, that happens in Australia somewhere between 0.5 and 2.5%. But it's dependent upon the rate of antibiotic resistance, because your doctor will have given you an antibiotic just before the procedure. And we all know that as antibiotic resistance increases around the world, it will increase in Australia, and the effectiveness of the prophylaxis will decrease. The United States data, the randomised control study, has just published some data which shows the most frightening data, which says that for every 333 men who have a TRUS biopsy, one of them will die. And it doesn't matter whether you've got a cancer, it doesn't matter whether you're a young man or an older man, the risk is about the same in terms of age, although it's increased if you have a cancer. In Australia, sorry, that's better. In Australia, if we were to apply the American data and the European data, we could expect 50 to 60 deaths from the TRUS biopsy every year. So, in 2009, 29,000 men had a TRUS biopsy. What should I do? Should I keep going? You didn't give me a bell. You didn't give me a bell. 29,000 men have a TRUS biopsy. So may I have my minute? May I have my minute?
You can answer questions later.
Okay.
You've got 5 seconds to make a point.
And there's your data, ladies and gentlemen. 50 people will die, and look at the number. 19,000 men who didn't have cancer were killed by a TRUS biopsy. Thank you.
Okay, that was totally my fault because I was so distracted by so distracted by the ludicrous number of slides you tried to pass off as 3. And I was also waiting for that wrestling one to come back. And also, they don't look anything like walnuts. I mean, I don't know if those pictures are in any way related to prostates, but they do look like a vegetable salad, every one of them we see. I don't get who the medical artists are that you're using. Okay, so some interesting points made there in way too many slides. Some, heavy reliance on, I think there was evidence behind what you were saying. It wasn't just fact, for feeling and thought and what have you. We now come to our third affirmative speaker who is going to attempt to wipe the floor with everything that's been said by our negatives so far. And I have to say, not relying heavily on props at all, Dr. Urology at the Hobart Private Hospital, Michael Vaughan, man of mystery. If you ever try and look up a biography or an image for him on the so-called internet, you won't find one. So just why he's keeping himself in such a veil of mystery and secrecy, he may well now reveal. Join me in welcoming our third and final speaker for the affirmative, Dr. Michael Vaughan.
Has it started?
It hasn't yet. It hasn't yet. Don't say anything. Here we go.
Yes, well,
Start.
that's the kind of blinkered Philistine pig ignorance I've come to expect from you non-creative garbage. You sit there on your lonesome spotty behinds, squeezing blackheads, not carrying a tinker's cuss for the struggling urologist. I am a urologist, and prostate cancer is what I treat. I spend my life dealing with it. I eat, drink, breathe, sleep prostate cancer, day in, day out. The negative have tried to portray prostate cancer as inconsequential. All these cancers are consequential for the individuals and their families. These cancers cannot be swept under the statistical magical carpet that the prostaters here would have us believe. I might come over to this microphone here.
Yeah.
It's my privilege to treat men with prostate cancer, in many cases from diagnosis to cure, but in other cases it's from diagnosis to death. Men can have prostate cancer for many, many years being treated, and they can have to have treatment with hormone treatment, castration such as it is, radiotherapy and chemotherapy, and these treatments that have major long-term side effects. The negative would have you believe that these issues don't matter. We are the prost lovers, they are the prost haters. This debate is about compulsory PSA screening for men aged 50 to 69, and it is a very clear and straightforward proposition. The PSA test itself is simple, it's cheap, it's quick, it's reproducible, it's reliable, it's been validated for 25 years. It's positive in 2% of women. It is the most useful blood test for detecting any type of cancer. Bowel, lung, ovary, breast, brain, skin, pancreas, cervix. There's no blood test for it. There's a little wooden spatula on your cervix. There's your breast in a pop-up toaster. This is a simple blood test. PSA, it is providentially sent assistance. It's an incredibly helpful test. The negative will have you believe that the test is so negative. It will only detect cancers, or it detects cancers, but it will detect unnecessary benign things. Some of the benign things are also very, very important, and this annual testing in the population will reveal these things. The negative should be harping on about the anxiety of testing, but they haven't yet, but I hope the next speaker will. What about the benefits of annual testing? Mr. Jones, your test is normal this year. Another clear year. Well done, you're in the clear. Relax. We'll come to this. The compulsory screening. Screening must be compulsory. Men are useless at determining things about their own health. The testing must be compulsory. That is the only way it will work and the only way it will be done. Men go to great lengths throughout their lives to try and predict the future. They look on the internet all the time for the Bureau of Meteorology. What will the weather be tomorrow? Facebook, what are their mates going to do next week? They go to fortune tellers. They read the stars in the newspaper. For goodness sake, have a blood test that's going to show you so much more about your life and your future rather than relying on these spurious sources. PSA testing from 50 to 69. This is the time to do it. Less than 50, prostate cancer is rare. More than 69, that's when the action starts, that's when the trouble starts. This is the time to detect cancer. Hence, we need to screen for cancer, diagnose it early, treat it early if it is a cancer that needs treatment, and avoid the unnecessary problems. Men and their families have a right to know.
Oh. Ding-a-ling. Sorry, 1 minute.
Oh, crikey. Well, that's very, very difficult. Okay. Yep. Most people use statistics like a drunk uses a lamppost. The negative are no different. We're bombarded with all these unnecessary studies which are ancient, with these unnecessary facts and figures. It's ridiculous. The most important one that I have to rebuff, there's all this discussion about the transrectal ultrasound. For goodness sake, modern day contemporary urology, it is called a transperineal biopsy. The needle goes through the skin, not through the rectum, and there is no ingress of E. coli into the bloodstream. Thank you very much. Liesl is here. She's been doing genetics for all these years. She's found these genetic tests which can predict and show which cancers are significant and which ones are not. She has neglected to tell us that tonight, holding back, keeping you in the dark. Ladies and gentlemen, how much have I got?
4 seconds. 3.
Therefore, all
2.
men aged 50 to 69 must have an annual PSA test.
Woo.
We are the pros lovers. They are the pros haters.
Yes, I believe it's called an own goal, one of your statements there, but the rest were just so kind of on point. And, you know, I think a lot of what has been said, this so-called fact-based evidence, this so-called science coming from the other team, I think you've laid to rest really nicely there, Michael, with your this and that and your this business as well. So join me in thanking the only practicing urologist, the only man you should let put a needle in your perineum here tonight, Michael Vaughan. Thank you very much. Our final speaker has his work cut out for him. He thought he had the lucky job because third speaker, or you don't have to write a talk, you just rebut what everyone else has said. Third speaker for the negative, but they're all such a dog's breakfast here tonight, Paul. I'm not sure how you're going to go with that, but Paul Glazue is a Professor of Evidence-Based Medicine at Bond University, part-time GP. He's very much the evidence-based guy. He was the director of the Centre for Evidence-Based Medicine in Oxford for many years, and he's very big on removing the barriers to using high-quality research in everyday clinical practice. He may have some pointers, Michael, for you with the use of evidence in practice, but, you know, whatever. Everyone join me in welcoming Paul to nail the argument for the negatives and try and swing that vote away from the heavily positive one that we had at the start. Join me in welcoming Paul. Your time starts now.
Thank you very much. It's a pleasure to be here and take part in this debate.
Into
Such
the
an easy
microphone.
debate in many ways, but I think it reflects the very difficult decision, the fact that we're even having this debate. However, the arguments that I've heard from the affirmative team have actually been pretty weak so far. Have you heard anything convincing? Arguments like, I've had pap smears, so men should have PSAs.
No, I think that's a very good argument. but they should hurt more.
I own a white coat. What sort of an argument is that? and the own goal, women can be detected with prostate cancer using a PSA. I mean, what sort of arguments have they put forward? But there's a crucial point that they've actually missed. And I think Professor Nelson posed that the opposing team, what didn't consist of clinicians. Well, actually, I'm a GP, as you pointed out, so that was incorrect. But actually, it's not GPs or urologists or people from cancer councils that should be making this decision. The reason why we're having this debate is it's a difficult decision, and it's the men involved who have to make that decision. It's really their choice. And so, as you can see in this sign here from America, Thousands of men will die of stubbornness. Learn about the preventive medical tests. Well, what was their response to that? They painted it up. That's what they think of your tests. So, I'm going to have to be, this is actually a serious debate, so I'm going to be serious for a moment, Bernie, and you can have a little nap for about 2 minutes while I go through some details here. But we decided to ask men about this, to ask them what they think about it. And what did they think? Well, actually, it's a tough problem. And it's a tough problem because we tend to overestimate benefits. PSA is no guarantee at all. In fact, you've heard the evidence several times tonight that it may not even have any impact on mortality, and if it does, it's very small. And men are not routinely informed about the potential harms of screening that we heard Frank present about the deaths from biopsies, and also about all the ongoing problems after you've had treatment for what may have been a condition that you didn't need to have treated in the first place. And there's a lack of individual informed consent at the moment. So what we decided to do was to actually ask a jury of men. We got together 12 men like a jury, and we got them over 2 days to deliberate this question that you're being asked to think about tonight and to talk through the pros and cons. We had me speaking about what the downside was. We had a urologist speaking about the positive side, and we were on the end of the phone for the 2 days to answer any questions while they deliberated. And they called us quite often to ask us questions. Now, tonight's debate is not going to go into the same depth of detail unless are there people here who are prepared to stay till Saturday night for the whole 2 days? Okay, so we might have to trust that these men have heard all of the arguments, pro and con. They've deliberated them. They've thought about them. They've asked all the questions that you may not get a chance to ask tonight. And what conclusion did they come to? Well, this is the scientific plots, Bernie. You can go to sleep for a moment. And the men who'd had this said, no, this was no good at all. That's the blue line, the group who had it. We had a control group and they didn't change their minds. When we gave them a jury as well for 2 days, and that's the red line down the bottom here, they had the same thing. They became much less enthusiastic about screening. But we also asked them the specific question, and I'm just going to give you some of the data here that the affirmative side didn't give you. This is of 1,000 men who are going to be screened. Most of them makes no difference at all. They didn't need to go and have the test or have the blood taken. Most of the few that were going to die, for most of them, it makes no difference. This is no guarantee.
1 minute.
Okay. And some of them, lots of them will be harmed. 36 will be overdiagnosed having a cancer that never would have been detected otherwise, but was detected as an indolent cancer and they get all the treatment. And there may have been one life saved. Most people would actually die of other causes, though. 190 deaths from other causes. This is a minor thing. If you're smoking, the serious thing is to stop smoking, as Professor Nelson will admit. And their conclusion was, when they were asked the question, should government campaigns be provided for screening, and if so, what information should be included, they said the government shouldn't do this. There should be no universal campaign for PSA screening. What they said instead was that GPs like Professor Nelson should actually be informed about the sorts of facts that are in this figure, because they clearly don't understand them at the moment, and they need to provide them for informed consent to patients. So their overall conclusion was, as I started, they came up with this slide, no, we won't. Thank you.
Tough call. I'm feeling a little bit sorry for you to have to make this decision now, because now, after hearing both sides of the debate, you've got to vote again on whether you agree that all men aged 50 to 69 should have compulsory screening. That'd be your black one. So if you're a yes now, get your yes and pass it to the end. If you're a no now, get your no, the red one. No, all men aged 50 to 69 should not undergo compulsory painless screening. Oh, sorry, I thought it was compulsory. My mistake.
You keep making mistakes.
I keep making mistakes.
You're a prostate
I'm very impartial. No, I've got no feelings either way about the prostate.
It's a fundamental error.
It is a fundamental error.
It's a big decision.
It is egregious. It is egregious, my bad. I keep saying compulsory. I should be saying have annual prostate cancer screening. My mistake. Make sure you read it before you vote. Don't listen to the person up here giving the instructions very badly. Clearly they didn't listen with the counts on slides. All right, and now let's see if we can get the visual, and I'm going to ask you two to have a look, or you two teams to have a look here.
I have the vote results here, but before we even look at them, will you join me in thanking our speakers they've enlightened, they've entertained, they've broken all sorts of rules, boundaries and guidelines, but they have managed to sway, as we saw earlier. They swayed quite a few of our voters. Now, I'll just remind you what the before vote was. Saying yes, that men 50 to 69 should have annual screening, we had 121. Saying no, we had 85. Saying yes, we now have 88, and no, we now have 110. So we have done... Now, I mean, I'm just a dumb biochemist. Michael, can you help me work out who won there? Can you just...
I'm not very good at maths, that's why I'm a neurologist.
I think you're an accountant though, aren't you, Penny?
I think we need to applaud the other team, but I have to say they did use, I think I did count up the number of slides. We got to 29 slides, so that's...
29 slides.
Yeah, penalty. I want to introduce a penalty.
Introduce a penalty for slides. If we deduct one vote for every excessive slide, then it's about a tie. So, well done, congratulations. Stick around. We're sticking around for, is there more drinks and things now? Stick around and hopefully you get a choice to ask other questions if you want. I'll hand back over to Tom now to formally thank everyone. Thanks very much, it's been great.
Thank you, Bernie, and to both of the teams, and thanks to the audience for participating. I think it's been a wonderful debate. So it's traditional at this stage in the evening to give out some gifts. Bernie, you know, we're very concerned about your lack of a prostate. So we've brought you this Menzies Memorial Prostate. It's not Menzies Debate. Kind of your gift here.
In some countries, Tom, red wine is considered a gift. But anyway, thanks everyone. I feel part of the Walnut Club. Good on you.
Okay, ladies and gentlemen, thanks again for coming along, and thank you for your support of Menzies. I think the engagement of Menzies with the community is really a unique aspect of this institute, and we love seeing you here. Thanks for coming. Have a good evening.
Well fought.